Starting with case 1, a 23-year-old male presented with complaints of right eye diminution of vision since 1 week with blackish hue in the vision while reading. There was no history of trauma, fever, exposure to any laser, sun gazing, or any welding. There was no significant past ocular and medical history, and there were no history of similar episodes of such complaints in the past. On evaluating clinically, the best corrected visual acuity in right eye was 6 by 7.5, near vision N6, left eye was 6 by 6 and near vision was N6. The IOP was 14 in both eyes, anterior segment was within normal limits, and the fundus showed right eye small, pale, punctate lesions over the fovea, and left eye was within normal limits. Both eyes had tessellations in the periphery, and the rest of the periphery was within normal limits. After clinical evaluation, both eyes fundus photo OCT-A and fundus autofluorescence was ordered. This was the fundus photo of the right eye concentrating at the fovea. Pale hypopigmented punctate spots were seen in the right eye, around the fovea and within it, and the left eye was within normal limits. The periphery was normal. This can be seen closely, few pale hypopigmented lesions visible just around the fovea. So this is the area to be focused on. As ma'am said, we can see layers of vertical streak of hyperreflectivity. Just below the fovea is extending above the ELM up to the ILM, and the adjacent one is extending from the ELM to the outer plexiform layer. And the ELM is just subfoveally, the ELM is also irregular, and below that the EZ-IZ zone is also disrupted.
So there are fresh postgraduates also, they might not know ELM or EZ thing.
I'll see the full forms, ma'am. Yes, ma'am. The external limiting membrane is a little irregular, which is this layer. The outer 4 hyperreflective layers, the first I'm talking about is the ELM, and then just below that is the ellipsoid zone and the interdigitation zone. Both of them are irregular and hazy in appearance. The outer RP and the Brooks complex in this OCT appears intact only and is not pathological. This is the left eye OCT in which the posterior cortical phase is also quiet. No hyperreflective opacities are visible. The contour is maintained and all the layers are intact. So this is the right eye OCT angiography in which the superficial, deep and the avascular complexes are within normal limits, and as well as in the left eye all the 3 complexes were within normal limits. So then we move forward to the multicolor imaging. In the right eye we can see a red patch over here, and within it is heterogeneous and not homogeneous like in the left eye, and that heterogeneity, orange punctate spots are visible within that red patch in the right eye, while the left eye appears normal. So this is the infrared reflectance. Again, it is showing hyperreflectivity in this area, and the previous image is the composite image, and this is the infrared reflectance. So the infrared reflectance and the blue and the green make the composite image. We can see the blue and green composite were within normal limits only, and the infrared reflectance showed this hyperreflective spots in the right eye while they were absent in the left eye. Moving to the fundus autofluorescence, the blue autofluorescence was within normal limits, while in green fundus autofluorescence, there were subtle areas of hyperautofluorescent lesions in the right eye, while in the left it was normal. This was the infrared autofluorescence, again showing areas of little hyperautofluorescent areas, while left eye was normal. So we made the provisional diagnosis of acute fovealitis in this case, because since only the fovea was involved, sparing the RP and Brooks, which we saw also with the help of OCT-A, patient was asked to follow up after 2 weeks. So as we can see in the first image, it was the first, in the first visit, the colored fundus photo showed that hypopigmented areas. In the follow-up visit, this is the figure shown below is the follow-up visit. This shows again that the heterogeneity had reduced and the hypopigmented spots had reduced. This was after 2 weeks, and when the patient was followed up after 1 month, it was completely normal. No hypopigmented spots were visible, and the heterogeneity over the fovea was also gone. So there was no residual pigmentation actually present in this case. The changes which were seen in OCT were also there. This was the first visit showing the changes as we discussed initially. Then moving on to the visit after 2 weeks. So here we can see that the external limiting membrane has started becoming slightly regular than the previous scan, and the irregularities just below that at the level of ellipsoid zone and interdigitation zone was also recovering. And final follow-up visit, which was after 1 month, it has been completely restored without any residual defects. And again, RP and the other layers are intact. So this is how the autofluorescent image changed. This was the first visit. As discussed, on green fundus autofluorescence, we were able to see certain hyper autofluorescent lesions. Then on following up, it slightly reduced after 2 weeks, but it was still present. Then after that, it had completely gone, and it was just like the normal left eye. Moving on to case 2. So there was a 39-year-old female who presented with complaints of seeing a black spot in the right eye along with diminution of vision since 3 days. There was no history of trauma, fever or exposure to any laser. Patient had a history of LASIK surgery 15 years ago elsewhere, and systemically she was hypothyroid on medication. On clinical evaluation, patient had a vision of right eye 6/15, near vision N6, left eye vision was 6/6 and near vision was N6. Both eyes IOP and anterior segments were normal. Fundus showed clear vitreous, yellow-white punctate lesions over the fovea, and left eye was within normal limits and periphery was also within normal limits. After clinical evaluation, both eyes OCT, FAF and fundus fluorescein angiography was ordered. So here we could see a round orange lesion surrounded by a hypopigmented halo in the fovea, shown by the white arrow, with multiple tiny hypopigmented lesions also visible temporal to the fovea, seen by black arrow. So this was the multicolored image in which the few orange punctate lesions were visible at the center, also extending inferiorly to the fovea, and left eye was within normal limits. The infrared reflectance again showed areas of hyper reflectivity, while left eye was within normal limits. This was the blue autofluorescence, which showed few hyper autofluorescent spots in the right eye, while the left eye was normal. And these hyper autofluorescent spots corresponded with the lesions seen on the fundus examination. So in the
now someone else describe the OCT.
Vitreoretinal interface is normal with the compact fovea, and inner retinal layer is compact with the ALM layer is compact, and disruption in the ellipsoid zone and hyperreflective foci is seen in the RP layer.
So as here we can see, as said, that the vitreoretinal interface was normal and there was no areas of inflammation. The foveal contour was maintained. The inner layers appeared to be normal, and the external limiting membrane was slightly elevated. And again we can see a streak of hyperreflectivity, but not extending up to the internal limiting membrane, just up to the outer nuclear layer. The ellipsoid zone and the interdigitation zone are again disrupted here also, but the difference here in this case, we see that the retinal pigment epithelium is slightly thickened, and just above it the irregularity is present, while the left eye was within normal limits. This was the fluorescein angiography, the early phase and the arteriovenous phase. In the left figure, we can see these areas of transmitted hyperfluorescence, which on further phases did not leak, only staining was present, which was suggestive of window defects in this case. The left eye was within normal limits. So in this case, the provisional diagnosis made was of right eye RPE epithelitis. Patient was given short course of oral steroids after obtaining fitness, and patient was again followed up after 2 weeks. So in the follow-up visit, we can see this was the first visit and this is the second, that the area of vertical streak of hyperreflectivity was restored. The ELM slightly elevated was normal, and the ellipsoid zone and the interdigitation zone was also coming to normal only. But still some defect was still present. In the follow-up visit, a certain area of depigmentation was still left in all the images seen, not completely restored. Coming to the discussion of these two diseases and review of literature, acute foveolitis in this case was described by Spade et al. In Retinal Cases and Brief Reports published in 2022 to describe the first cases which were seen of having acute foveolitis and considering this disease as a separate entity from RP epithelitis. The hyperreflective deposits and the lack of pigmentary changes when, as we saw in our first case, and absence of any OCTA findings made them to suggest a new novel disease known as acute foveolitis. So in their case, this was the patient having a hypopigmented patch near the fovea, which corresponded to the infrared image also. The OCT is shown below, has this hyperreflective lesion just above the ELM, and these are the D and E are the other two patients in the same series taken. These hyperreflective globular lesions were reaching up to the ILM, and even in the D and E case even reaching above that. While we can see the RP is completely intact and there is no transmitted hyperreflectivity also below the RP. The OCT, this on the right side shows the follow-up image of the same patient. This was the first visit and this was the final visit after 4 months. In the first image, we can see the hyperreflective globular structure shown by the arrow and the discontinuity in these outer retinal layers. Then progressing further, this feather-like hyperreflectivity lesions were seen on follow-up and gradually resolving, and these outer retinal layers becoming continuous. And this was the final OCT of this patient. The vision became 6/6 and subtle discontinuity was present. Otherwise, the lesions had completely resolved. This was the OCTA image of the index case in this series. There was decreased signal noted as pointed by the arrow, and the OCT shows decreased reflectance at the same spot. And the third one is the compensated image formed, which showed no flow abnormality. The other case which discussed the variants of presumed acute foveolitis cases published their case in Retinal Cases and Brief Reports again in 2022. They had 4 cases. This is the first presenting fundus photo of the patient showing subtle yellow lesions at the center of the fovea. The infrared image again showing the hyper autofluorescent areas, and this was in the follow-up visit that the hypopigmented lesions had resolved. And they also, in multimodal imaging, they also included ERG and noticed reduced responses in the central peak. And in their case, this was the patient having no problem in the RP and the Brooks area, while vertical, actually oblique hyperreflectivity lesions were seen just above the RP. And this was the follow-up visit when those lesions, vertical hyperreflective oblique lesions, had resolved on follow-up of 2 months. This was the other patient which was seen. The right eye again showed hypopigmented pale lesions. The FFA and the autofluorescent both were unremarkable, did not show any changes. While the OCT again showed mottled hyperreflective lesions outer to the external limiting membrane, which resolved on follow-up. This was the third case taken in this series, but their diagnosis remains doubtful because, as we can see here in this case pointed by the arrow, there is a certain area of transmitted hyperreflectivity. So doubtful that this case falls in the same category or not, but they have presumed it as acute foveolitis only. So the case we discussed today regarding foveolitis has been published by Aarzoo sir in Indian Journal of Ophthalmology. Moving on to discussion about acute retinal pigment epithelitis, Kalina et al. Published this was the first case series published of acute RP. So in that time, it was published in 1987. It was first seen in 1972 by Krill and Deutman and has the name of Krill's disease on the basis of that. So in that initial era, they did not have much imaging, only fundus photo and FFA was done. The fundus photo of the various cases, case number 1, 2, 3 and 4 is shown, and they tried to show that the residual hyperpigmentary changes were seen even on follow-up, even if the vision had restored completely. These were the 4 different cases of this series. These were the case 1, 2 and 3 FFA shown, which showed transmitted hyperfluorescence, and staining was seen without any leakage. Then moving on to other case with acute retinal pigment epithelitis, which studied the OCT findings in 18 cases, and it was published in 2014. So they had multiple cases in which the OCT, FFA and fundus findings of the patients were seen. In the first, we can see there is only slight irregularity at the level of ellipsoid zone, while there is subtle irregularity also at the level of RP, shown by 2 arrowheads, which improved on 2 months, but residual irregularity was still present. And FFA also showed changes. In the next case, the baseline, very subtle changes seen, but the vision was 20/30. After 1 month, there was no residual irregularity seen. The third case showed irregularity at the starting from external limiting membrane, and again there was transmitted hyperreflectivity below it, shown in the gap of between 2 arrowheads, which resolved on follow-up. Multicolor imaging in a case of acute RP epithelitis. This was published by Aarzoo. This case has only been discussed previously. So foveolitis is another term which has been seen and known as an indicator of dengue fever. One of the case is discussed here. As we can see, fundus image of the patient, right eye has a normal fundus, and the left eye fundus reveals superficial retinal hemorrhages, shown by the black arrow, and ill-defined tiny yellowish subretinal lesions at the center of the posterior pole, shown by the yellow arrow. And this is the on right side shows the right eye, which is normal, but the left eye had perifoveal capillary leakages in the late phases. And the OCT shows the bracket which is put shows the intact RP, while hyperreflective lesions shown by the vertical hyperreflective lesions shown by the yellow arrow is seen. And again, in this case also, they extended up to the above the ILM, internal limiting membrane. So this was on follow-up when the lesions were progressively becoming better, and in the final OCT we can see there are no residual abnormalities, no residual pigmentary changes, and the lesion had completely resolved, and the vision was also restored. So diagnosis of these diseases is important as it has a good prognosis without any treatment. And multimodal imaging helps to differentiate the diseases which can look similar on indirect ophthalmoscopy.
Thank you, Aarzoo, for the well-documented cases.